Hey guys, welcome to the Module 11 Synopsis, Eating Disorders. Have a look at these module objectives and make sure that you've met them. If you haven't, go ahead back through the lessons and see if you can find any material that helps you put everything together. How will you apply one of these objectives in practice? Eating disorders are serious medical illnesses, and the way that we talk about them with other people matters. In subchapter 13.2, figure 13.1, there's a little flyer that's some facts about eating disorders, and I'm going to review those. Eating disorders are medical illnesses. Genetic and environmental factors can influence eating disorders, and eating disorder is not a trend and it's not a choice. Eating disorders are serious and they can be fatal. They involve serious medical complications that can cause permanent damage or death. People with eating disorders also have an increased risk of death by suicide. These disorders can affect anyone. They do not discriminate. They affect people of all ages, races, ethnicities, and genders. You can't tell if someone has an eating disorder by looking at them. People with these disorders can be underweight, normal weight, or overweight. Family members can be patients' best allies in treatment. These disorders are caused by a combination of genetic, biological, behavioral, psychological, and social factors. Family members do not cause eating disorders, and they can be a great source of support. It's possible to recover from an eating disorder. Complete recovery can happen with treatment and time. Next, let's review what you learned about anorexia nervosa. This is a condition where people avoid food, severely restrict food, or eat very small quantities of only certain foods. They have an intense fear of gaining weight or becoming fat, even if they are significantly underweight. People with anorexia nervosa often have distorted body image and view themselves as overweight. The subtypes are restricting and binge eating and purging. So signs and symptoms of anorexia nervosa are severely restricted eating, extreme thinness, relentless pursuit of thinness, and unwillingness to maintain a healthy weight, intense fear of gaining weight, distorted body image, and denial of serious low body weight. Other things that may develop over time are thinning of the bones, anemia, muscle wasting, brittle hair and nails, dry and yellowish skin, growth of fine hair all over the body, severe constipation, low blood pressure, slow breathing and pulse, drop in internal body temperature, lethargy, sluggishness, or feeling tired all the time, infertility, damage to the structure and function of the heart, brain damage, and multi-organ failure. So you can see this eating disorder has serious long-term consequences. Now let's talk about what you learned about bulimia nervosa. This is a condition where people have recurrent and frequent episodes of binge eating unusually large amounts of food in a short period of time, while also feeling a complete lack of control over these episodes. Binge eating is followed by behaviors used to eliminate the excess food, like forced vomiting, use of laxatives or diuretics, fasting, excessive exercise, or a combination of these behaviors. People with bulimia nervosa may be slightly underweight, normal weight, or overweight. Signs and symptoms include chronic inflamed and sore throat, swollen salivary glands in the neck and jaw, worn tooth enamel, and increasing sensitivity and decaying of the teeth as a result of exposure to stomach acid, acid reflux disorder and other GI problems, intestinal distress and irritation from laxative abuse, severe dehydration, electrolyte imbalance such as sodium, calcium, potassium, and other minerals, and this can lead to dysrhythmia and cardiac arrest. Just like anorexia nervosa, bulimia nervosa can have long-term implications and lead to severe damage, injury, or death. On to taking a look at what you learn about binge eating disorder. This is the most common eating disorder in the United States. It's a condition where people lose control over their eating and have recurring episodes of eating unusually large amounts of food. Unlike bulimia nervosa, periods of binge eating are not followed by purging, excessive exercise, or fasting. As a result, people with disorder are often overweight or obese. There are signs and symptoms for binge eating disorder, and they are eating unusually large amounts of food in a specific amount of time, such as, say, a 2-hour period, eating even when they're full, eating at a fast pace, eating until uncomfortably full, eating alone or in secret to avoid embarrassment, feeling distressed, ashamed, or guilty about eating, frequent dieting, possibly without weight loss. The stress that binge eating disorder puts on the mind and body cannot be overlooked. This is a disorder that also has significant psychological and physiological consequences. In learning about these three main eating disorders, what did you find to be a common etiology? There are a couple of other eating disorders that are not classified with the rest of them. Pica is another type of eating disorder in which an individual repeatedly eats things that are not considered food and that have no nutritional value, like paper, dirt, soap, hair, glue, or chalk. People with pica do not usually have an aversion to food, and ingestive items vary with age. The behavior is inappropriate to the developmental level of the individual and is not part of culturally supported practice. A person diagnosed with pica has the potential for intestinal blockages or toxic effects of substances consumed, such as lead poisoning from paint chips. Treatment for pica involves testing for nutritional deficiencies and addressing them if needed. Behavioral interventions used to treat pica include redirecting the individual from the non-food items and rewarding them for setting aside or avoiding the non-food items. There's another disorder called avoidant restrictive food intake disorder, or ARFID. This is a condition where individuals limit the amount or type of food eaten. Unlike anorexia nervosa, people with ARFID do not have a distorted body image or extreme fear of gaining weight. ARFID is most common in middle childhood and usually has an earlier onset than other eating disorders. Many children go through phases of pickiness, but a child with ARFID does not eat enough calories to grow and develop properly, and an adult with ARFID does not eat enough calories to maintain basic body function. Signs and symptoms: dramatic restriction to the types or amount of food eaten, lack of appetite or interest in food, dramatic weight loss, upset stomach, abdominal pain, or other GI issues with no other known cause, limited range of preferred foods that becomes even more limited, like pickiness that becomes progressively worse. Sometimes people with ARFID limit their food based on texture, based on taste, based on temperature. So there are a number of different ways that they categorize their food to avoid them. Body mass index, or BMI, is a person's weight in kilograms divided by the square of height in meters. BMI is an easy screening method to determine if an individual's weight is classified as underweight, healthy weight, overweight, or obese. However, it is important to remember that BMI is a screening method. It does not take into account muscle mass, bone density, overall body composition, racial and sex differences. For children and teens, the interpretation of BMI depends on their age and sex. After a BMI is calculated for children and teens, it's expressed as a percentile obtained from either a percentile calculator or a growth chart. Like many other mental health concerns and disorders, the exact cause of eating disorders is not fully understood. But research suggests that a combination of genetic, biological, behavioral, and psychological, and even cultural factors can increase a person's risk. Eating disorders are hereditary. Researchers are working to identify DNA variations that are linked to the increased risk of developing eating disorders. Even though genetics increases the risk for developing an eating disorder, the individual's environment plays a significant role. Onset can occur at nearly any point in the lifespan, but eating disorders commonly start in adolescence and young adulthood when there can be exceptional pressure from peers, social media, advertisements, etc. to diet and lose weight. For people that are vulnerable, this can be particularly influential. As you consider the genetic, environmental, and social influences of eating disorders, recognize that the combination of these factors can affect the severity and presenting characteristics for each client. Additionally, although eating disorders are commonly thought of as affecting young women, it can affect people of all genders, ages, races, ethnicity, body weights, and socioeconomic statuses. People with body weight or BMI within normal ranges can have eating disorders. Some cultural considerations. Cultural beliefs impact self-concept and satisfaction with body size. Anorexia nervosa is associated with cultures that value thinness. Additionally, studies indicate that social media significantly influences these beliefs. For example, there's a study that found that participants with a higher use of social media had a significantly greater risk of valuing thinness and having eating disorders. Black and Hispanic teenagers are more likely to suffer from bulimia nervosa. Additional considerations are influences of some sports cultures on athletes where weight is a consideration. such as wrestling, gymnastics, figure skating, and bodybuilding. Which risk factor or cultural consideration surprised you? So, what about treatments? Early treatment is important for individuals with eating disorders because of increased risk for suicide, self injury behaviors, and medical complications. People with eating disorders may also have other mental health disorders such as depression or anxiety or problems with substance use. There are a variety of treatment methods that can be used: individual, group, and/or family psychotherapy, medications, nutritional counseling, medical care, and monitoring. For psychotherapy, the cognitive behavioral therapy is used to reduce or eliminate binge eating and purging behaviors. Individuals learn how to identify distorted or unhelpful thinking patterns and recognize and change inaccurate beliefs. Family-based therapy is a type of psychotherapy where parents of adolescents with anorexia nervosa assume responsibility for feeding their child. This therapy has been found to be very effective in helping adolescents gain weight and improve eating habits and moods. Medication. So there's some evidence to suggest that medications like antidepressants, antipsychotics, or mood stabilizers may also be helpful in treating eating disorders and other co-occurring mental illnesses such as anxiety and depression. Anorexia nervosa specifically. The standard treatment for clients with anorexia nervosa includes nutritional rehabilitation, psychotherapy, and acutely ill patients who do not gain weight despite the standard treatment may be prescribed olanzapine, which is a second-generation antipsychotic, or an antidepressant for concurrent depressive disorders. Nurses should keep in mind that low-weight clients are at an increased risk for side effects. Additionally, medications such as antidepressants and antipsychotics can impact cardiac function. Bupropion is contraindicated in clients with eating disorders because of an increased risk for seizures, and tricyclic antidepressants should not be used because of their cardiotoxicity. Bulimia nervosa specific. Fluoxetine, an SSRI, may be prescribed for adults with bulimia nervosa even in the absence of depressive symptoms. If fluoxetine is not tolerated, other SSRIs may be used. However, bupropion is contraindicated in clients with bulimia because of the increased risk of seizures. So for binge eating disorder, obese clients with binge eating disorder who do not respond to psychotherapy are encouraged to participate in behavioral weight loss therapy. SSRIs, anticonvulsants, or stimulants may be prescribed for clients with binge eating disorder. Nutritional counseling. This is done by a dietitian with specialized training that's necessary for individuals with eating disorders. The counseling should incorporate education about nutritional needs as well as planning and monitoring healthy food choices. For medical care and monitoring, there are medical care treatments for eating disorders that can be delivered in a variety of settings. There's intensive outpatient, where the client is medically and psychiatrically stable, does not need daily medical monitoring. The symptoms are under sufficient control for the individual to be able to function in normal social, educational, or vocational situations and continue to make progress in recovery. Partial hospitalization is also when the client is medically stable. The eating disorder impairs functioning but is without immediate risk. The client requires daily assessments of physiological and mental status. The client is also psychiatrically stable but is unable to function in a normal social, educational, or vocational situation. There's residential treatment, where the client is medically stable and requires no intensive medical interventions. They are psychiatrically impaired and unable to respond to partial hospital or outpatient treatment. And finally, there's inpatient treatment. That means the client is medically unstable, either with unstable or depressed vital signs, lab findings that present an acute health risk, complications due to coexisting medical problems like diabetes, or they're psychiatrically unstable with rapidly worsening symptoms, suicidal ideation with the plan, and it is not feasible to implement a contract for their safety. Let's review the application of the nursing process to eating disorders in a quick chat. People with eating disorders may appear healthy even when they are very ill. Additionally, individuals with anorexia nervosa often do not view their behavior as a problem. They're typically only seen in healthcare settings due to concerns of family and friends who have encouraged them to seek treatment. Conversely, individuals with bulimia nervosa or binge eating disorders may feel shame and sensitivity to the perceptions of others regarding their illness. Therefore, it's vital for the nurse to build a therapeutic nurse-patient relationship with the client that has an eating disorder and empathize with the possible feelings of low self-esteem and over their lack of control of eating. Assessment. When you're assessing an individual with a potential or diagnosed eating disorder, it is vital to obtain their perception of the problem while assessing for signs and symptoms. Care planning that does not address their perspective will not be effective. Subjective assessment. A complete nursing assessment includes health history, psychosocial assessment, and a screening for the risk for suicide or self-harm. Nutritional patterns, fluid intake, and daily exercise should also be assessed. If the client has a binging or purging pattern, the amount of food eaten and or the frequency of these behaviors should be assessed. Some assessment findings from an objective standpoint in anorexia nervosa would be low weight, muscle weakening from starvation and electrolyte imbalance, peripheral edema from hypoalbuminemia, cardiovascular abnormalities like hypotension, bradycardia, and heart failure from starvation and dehydration, abnormal lab results like hypokalemia and anemia from starvation, amenorrhea, which is lack of menstruation, lanugo, which is growth of fine hair all over the body, cold extremities, constipation, impaired renal function, and decreased bone density. In bulimia nervosa, you may see normal to slightly low weight, muscle weakening from electrolyte imbalance, peripheral edema from rebound fluids if diuretics are used, cardiovascular abnormalities like cardiomyopathy, and cardiac dysrhythmias from electrolyte imbalances. Electrolyte imbalances include hypokalemia, hyponatremia from diuretics, laxatives, or vomiting, tooth erosion or dental caries, parotid swelling, calluses or scars on hands, and seizures. Make sure you're reviewing your client's diagnostic and lab work. Lab work can include the CBC, electrolyte levels, glucose level, thyroid function test, ESR, and CPK. Some diagnostic testing could be an electrocardiogram or dual energy X-ray absorptiometry or DEXA scan to measure bone density. Common nursing diagnoses: imbalanced nutrition less than body requirements, risk for electrolyte imbalance, risk for imbalanced fluid volume, impaired body image, ineffective coping, interrupted family processes, chronic low self-esteem, powerlessness, risk for spiritual distress. Outcomes identification. These are some typical overall treatment goals for individuals with eating disorders: restoring adequate nutrition, bringing weight to a healthy level, reducing excessive exercise, stopping binge purge and binge eating behaviors. Planning and intervention. Planning depends on the acuity of the client's situation. Clients are hospitalized for stabilization, and if they are in an outpatient setting, your planning is going to be completely different. Common criteria for hospitalization include extreme electrolyte imbalance, weight below 75% of a healthy body weight, arrhythmias, hypotension, temperature less than 98 degrees, or risk for suicide. Implementation. Nurses individualize interventions based on the client's clinical status and their phase of treatment. Interventions can be categorized based on the APNA standards for implementation and includes coordination of care, health teaching and promotion, pharmacological, biological, and integrative therapies, milieu therapy, and therapeutic relationship and counseling. Take a good look at subchapter 13.4, table 13.4b for some great examples of nursing interventions by APNA subcategories. Inpatient care. If the client's exhibiting a risk for suicide, a safety plan should be immediately implemented. Severely malnourished clients may require therapeutic enteral nutrition. If you've got a client that has had negligible to no food intake for more than 5 days, they're at risk for a potentially fatal complication called refeeding syndrome. The hallmark feature of refeeding syndrome is hypophosphatemia. It may also involve serious sodium and fluid imbalance, changes in glucose, protein, and fat metabolism, thiamine deficiency, hypokalemia, and hypomagnesemia. To avoid this syndrome, a thorough nutritional assessment must be performed, followed by the slow reintroduction of nutrients and fluids according to evidence-based guidelines. For outpatient care, or partial hospitalization being an option, they're medically stabilized. In this setting, the clients are in a clinical setting during the day and go home to practice skills in the afternoon. A significant part of the recovery process includes rebuilding relationships with family. Family members and close friends often feel frustrated and hopeless because previous interventions were not successful. On to evaluation. Evaluation is a continuous process of reviewing a client's progress towards their individual goals and SMART outcomes. Interventions are continually evaluated and modified based on their success in meeting these short-term goals. Nice work, everybody, and keep smiling. If you weren't smiling to begin with, try starting.